Please give your name and where you live.
Craig Scyther, Cincinnati, commonly referred to as Northern Kentucky, but we have Cincinnati right across the river. I have two questions. So say if someone has their primary in their pancreas, if the primary is removed from the pancreas, does success of CAPTM work as well on the metastatic disease, or does treatment have better success on an unresected primary in the pancreas?
So the data that Jonathan Strasberg collected only has a shrinkage of the primary about 18–20% of the time. So, but metastatic sites will shrink 75% of the time, by at least half. So we don't know why that environment is different in the liver than in the pancreas, but the pancreas is avascular for the most part. It's the tissue environment is significantly different. So that's where we think some of the resistance might be. Blood flow getting into those primary in the pancreas because of the relatively avascularity. We think about these tumors being vascular, but we think about adenocarcinomas, for instance, one of the more difficult tumors, or really not. We cannot adequately get our drugs in. So these neuroendocrine tumors, we have no way of measuring what our drug uptakes are, but we usually don't see shrinkage of primaries. We know the primary can get us in trouble. We respect it, and we want it gone, and our chemo drug just won't do it.
Dr. Suarez has a very interesting trial coming up. Actually, you activated in this field. Would you like to kind of give us a little plug about your study?
Is on? Sorry. Oh, far. Okay. So yeah, thank you. That's an interesting question. And as Dr. Anthony was mentioning, we don't have a well-established role to doing chemotherapy before the resection of the tumor if it's just isolated to the pancreas. So unless the tumor is not going to come out without at least we trying, we typically don't do the chemotherapy up front. What we do not know, and there is a study going on that opened late last year to try to understand, is that if you remove the tumor in the pancreas, and you know that this tumor has some features that are suggestive that the tumor might come back in the next 3, 5, 10 years, doing the CAPE-10 chemotherapy after the resection, doing this, that decrease the rate of the tumors coming back. We don't know the answer to that. Right now, the standard has been you remove the tumor in the pancreas, that's it, you are done. You just come back every 6 months or every year to get your scans. But the NCI opened this trial that is actually looking at doing just observation versus flipping the coin. You enter the trial and you get randomized to potentially receive the chemotherapy pills for 4 months, and they will study whether or not doing the pills is going to decrease the rate of recurrence. So that can be potentially practice changing in how we do our approach, and hopefully will help to increase the rate of cure for this disease. So ask your doctor about this trial. Thank you.
Hi, I'm Kathy Allen. I'm from near Knoxville, Tennessee. I have a question. I have a relative that seems to be showing some symptoms, but the insurance won't approve a CT scan. What kind of test would you recommend? Would a chromogranin A test show something, or to prevent this long extended diagnosis, what would be the best recommendation?
So chromogranin is very nonspecific, and sometimes it leads us on a wild goose chase, and at the end of that we have nothing. So I would follow what your primary practice provider's doing. There has to be some trust with your healthcare team. Generally, the magic word for getting a CT scan, ready for this, you want to write it down? Pain. Okay? You got to have pain. You can have other things too, but involuntary weight loss, that usually will get you a good CT scan. So, I mean, there's a variety of things that will. I'm being a little facetious here. But insurance companies are looking after the till, and the history of what's going on is what they're putting it as a risk assessment, and they're saying that they're, from their perspective, the risk is low. No one can say zero, I think, but we get this, we do what are called peer-to-peer, and healthcare providers are going to have to step up to the plate and discuss and require peer-to-peer and become an advocate. So there needs to be a patient advocate, and then the physician can do that peer-to-peer, and if there's enough data, it'll get done.
Again, depends on site of primary and what we're following. If we're considering liver debulking, MRIs have a little bit more sensitivity, so depending on the degree of metastatic disease in the liver, we'll follow with MRIs interchanged with CT scans. Otherwise, we use CTs. We typically don't follow with a DOTA scan necessarily unless, for whatever reason, we think that there's recurrence that we're not otherwise seeing.
I think I just want to add to that for the CT scans, it's important to have a multi-phase CT because there's ways of doing the CT scans, and you have to have the timing of the contrast getting right. So you have to have the arterial phase. And there is plenty of publications that show that if you do a single phase CT, you miss a lot of potentially spread in the liver. So having what's called a multi-phase CT with the arterial phase of the contrast is very important. Many times patients come to see us and they have just a simple CT, and then they're like, I'm sorry, you have to do another CT because we didn't get the CT in the way that we needed. And that's key if you're having planning for surgery.
Judy Vincent, Boise, Idaho. Does having a congenital heart defect increase the chances of getting carcinoid heart, and what would the symptoms be?
No, not necessarily. If you have PFA, then you can potentially have, in addition to the right-sided failure, you could have left-sided failure as well. If you have carcinoid syndrome and you already had a baseline a cardiac issue, obviously you have to monitor much closer to make sure that doesn't get worse with your valves in the right side being affected by the disease.
Quick question, a follow-up on that. Is it still standard procedure that a carcinoid syndrome patient should have an echocardiogram every year?
If patients have carcinoid syndrome, they definitely should have a baseline echocardiogram. If the 5-HIA that's being monitored either in the urine or in the blood, you know, that 24 hours urine test that you guys normally have to do it. I know it's painful to collect 24 hours urine, and in many places now we can do the blood version of that. But if it's high, I typically monitor with echocardiograms once a year. If they're not high, I don't necessarily follow every year. But I would be super curious to see what.
So I think there's risk categories you can put people in, and as Dr. Suarez said, the syndrome patients are the highest risk categories. The only problem that we have is that you can't just use a single number like serotonin 5-HIA to look at risk per se, because we've seen carcinoma heart disease even people at lower risk, and that's where how often you get it's going to really be dependent on the patient determinant. But if they've got liver mets, and we're controlling them, but we do think they're secretory to a certain extent. Baseline echoes are easy to do, and then the serial follow-up is a little bit where we may differ a bit how often to get it. There's no fixed guidelines there, but I think having your antennas up is the number one requirement here. Suspect it, because clearly they're at risk.
Good morning. Good morning, everybody. My name is Tim. We're from Cleveland, Ohio, and this is my wife, Doreen. I'm the patient, and I'm very grateful to be here with you all because I was diagnosed in November of 2020, so it's nice to meet you and be here with you all. My question is surgically based. So if you have innumerable mets in the liver, big ones and little ones, is there a thought to doing PRRT first because it could address the little ones, and then go in later and cut the big ones out? And then along that same line, is there a threat of cutting out the big ones, and then you don't have a lot of liver left, and then you want to get PRRT to get the little ones? So I'm just curious about trends or thoughts about that.
You should come to our tumor board. Really excellent question, and one we don't have an answer to. We do have some data, though our medical oncologist doesn't believe it, that we think there might be a benefit to resecting the tumors that are larger than 3 centimeters first, because you'll get more directed treatment to the smaller lesions. We do not infrequently think about taking out the larger tumors if we see them changing rapidly, because like I said, we want to preserve as much liver as we can, and as those things continue to grow, we're going to have less liver left behind if we don't necessarily move kind of quickly. Sometimes getting approval for your PRT or starting on it, and we don't necessarily know how you're going to respond. So there is a role for upfront surgical debulking of the larger metastases, knowing that we're not going for a 70 or 90% cytoreduction. Conversely, you can also argue that, depending on the exact pattern, how many large ones you have, exactly where they're sitting, it might be beneficial to do the PRT first, and then you can still go back in. The challenge with the PRT, and we've seen it more in the mesenteric disease in patients who have had small bowel tumors, and then we go in after PRT, it's a little bit stickier, it's a little bit more fibrotic, and it's a little bit more challenging. A lot of times the liver metastases patients that get PRT don't necessarily have surgical treatment is not one of the premier options, and so we've typically resected first. We just don't have enough data to say, hey, it complicates the surgery if we do PRT first. But that's something that we're also thinking about, because sequencing is important in that way.
Just one more question. Assuming a well-differentiated neuroendocrine tumor, is the dotodate scan ever employed when a PNET is within that 1 to 2 centimeter, less than 2 centimeter, or is it only use more conventional imaging like the CT or MRI?
For growth, we don't use the dotodate scan, because if you think, the way you think of PET and dotodate scans is there's basically like this whole halo effect. So the tumor can be really tiny, but there's a ton of light. So it doesn't really allow me to kind of assess growth. You may consider doing a dotodate scan if you want to look for like nodal metastatic disease, or if something looks suspicious. Sometimes patients will come to you after having had a procedure, we'll get a CT scan, and then there'll be a lymph node that looks concerning, and you don't know, is that inflammatory because this person just had a biopsy? Is that a MET? Is that something that should suggest that we remove it? You can consider a dotodate scan in a well-differentiated tumor to follow just size, MRI or CT.
Can you guys talk a little bit about the Signatera and Guardian blood tests for low-grade patients?
Dr. Torres leads the sort of national committee.
CARS is a company which now recently developed a precision alliance program for neuroendocrine tumors or neuroendocrine neoplasms, and they're going to be studying more and more. That just started maybe 8 months ago, so we'll be having more data. So I don't routinely use and send genetic testing on the tumors at the very initial time of diagnosis, because I don't think it's going to necessarily change my treatment plan, right? We know, at least for the beginning, typically we know what to do. So I don't send out for the mutations on the tumor at that time. If time passes and things are changing, the tumors are becoming more aggressive, or we are running out of options, I consider doing another biopsy and then getting the mutation analysis on the tumors at that time. Signatera is a blood test that just tells you if there is circulating tumor cells floating on your blood from the tumor, and they actually match. For Signatera, you have to have tissue. Then they will get the tissue. They will develop assay specific for your tumor, and then they will go in to test that against the blood. So we are not using that quite yet for neuroendocrine tumors to assess for progression, to see if that's going up, or to assess for recurrence. There might be something to be done in the field. I'm actually discussing with the company, and I'm drawing Signatera testing in some of my patients, which I hope later to collect and try to understand better when and how we can use Signatera for neuroendocrine tumors. We do a lot of Signatera for other GI tumors. I don't typically use Guardian, so I would love to see Dr. Anthony's expertise on that.
So Guardant is a blood test that we can look in the blood for what's called cell-free DNA. So this is a little. We're not looking at the whole cells per se, like maybe Signatera is. But the issue with neuroendocrine tumors is the reason Dr. Suarez and myself don't rely on next-gen sequencing on the early stages to determine therapy choices is because the neuroendocrine tumors usually don't show a lot of mutations. So it's a low likelihood that it's going to influence what we do. So the Guardant test and these tissue-based tests are important if it doesn't look right. You know, if we're looking at maybe some acceleration of what the disease is doing, transformation, then we'll consider rebiopsying and then matching that potentially with a blood test. Sometimes we can get both. We would prefer to have both, but and then sometimes we're sort of say, well, the blood works better than not getting anything at all. So it tells us what some of the mutation tumor burden is. That's a sort of another abbreviation, TMB, tumor mutation burden, that we'll look at possibly to predict response to immunotherapy. So we get some clues. It's not 100% a correlate or not, but we're looking for mutations. We're looking for things that are giving us clues that we don't have from our original pathology or from the scans.
Just to complement that, this is for the well-differentiated tumors. If someone has a poorly differentiated carcinoma, which is a much more aggressive tumor from the get-go, my practice, and probably your practice as well, is to send it for genetic testing right away, because the options are limited and time can run out very quickly.
We have time for one more question, and then we're going to go to break.
My name is Ken Covey. I'm from Cincinnati, and I'm on the clinical trial with Lutathera therapy and triapine drug. And prior to that, I was on Somatostatin, the octreotide, as my regular therapy since 2018. I've always thought that the Somatostatin exacerbated the symptoms, particularly of diarrhea, and I'm encouraged to continue that therapy while I'm on this clinical trial. I don't like it. Can you comment, please?
So there's somatostatin analogs are a double-edged sword. So while we are shutting down the secretory diarrhea, we're exacerbating what's called steatorrhea. So the somatostatin analogs decrease the pancreatic exocrine function to a certain extent, not enough for us to start off giving pancreatic enzyme replacement. But if there's weight loss and severe steatorrhea, then we may consider that as an option. So it's a trade-off. What's the cause of the diarrhea? Is the somatostatin analog causing more steatorrhea? And if there was a period of time where we may hold it, would the secretory form come back? The problem with somatostatin analogs, it's not 100% effective 100% of the time. So we may supplement the long-acting with the short-acting. So that factor has to be tuned in as it relates to timing. Is it just the week before the octreotide depot is due? So there's a lot of factors that go into it. So it's a little bit of trial and error. I think Dr. Thor, he's got a specialized blood test that can tell you whether it's bile acid colitis. That bile acid, because that's one of the things that can do it. If you've had your gallbladder out or such, the bile acids now are leaking into the colon, causes a colitis, and this magic blood test will tell you exactly what's going on. Just found out about it yesterday, so I'm going to order it on every diarrhea patient I've got. See, he's here, right? Where is he? Yeah, he's back there. Yeah.